Good afternoon. My name's Dr. Phil O'Connor from Leeds. Apologies for not being there in person, but unfortunately we seem to have been caught out by some hot weather and transport problems. For the next 30 minutes, I'm going to be talking to you about imaging of upper limb injury in golf. I first joined the Medical Advisory Board for the European Tour in 2008 and then became active in the European Tour Performance Institute when that was formed a few years later. For those of you that don't know, the Medical Advisory Board comprises Chief Medical Officer, which is currently Andrew Murray, physiotherapists and allied health professionals, radiologists and clinicians, predominantly surgeons and sports scientists. And the medical service is predominantly delivered via this medical facility, mobile medical facility, which is present at all PGA Tour events. And it's predominantly provided by sports physicians and the AHPs on this bus. We do, however, also have a medical team that provides specialist opinions with radiologists, in my case, present at 4 to 6 tour events every year. We also have upper limb surgeons. There is a hip surgeon who comes to some events, and we have skin specialists, psychiatry, strength and conditioning and nutrition, all of which form vital components of the medical care to these players. In terms of radiology, we can provide ultrasound. At the front of this bus, actually it's the back of the bus, there is a small consultation room which has an ultrasound machine in, which is a GE portable machine that really offers very high quality imaging. We have the latest 420 matrix probes on it, so yeah, I'm pretty confident we can use ultrasound to just about the same level that we can in the hospital departments. And this allows us to perform high quality diagnostic ultrasound and interventions on these players. We also have an MR review station where we can review MRs that are either performed on site or are undertaken in between events, and the players bring their imaging data with them. And with all these multifaceted elements to the medical service, we really are the links in the chain that provide a very complete medical care for these players during their years on tour. Golf is a very interesting sport to image. In the same way that there are many ways to swing a golf club, there are also, as a result, many ways that you can injure yourself. So we see a broad spectrum of injury in our golfers that is really very challenging to image. If you look at the mechanisms of injury, this is a paper from the American Journal of Sports Medicine in 2003. You can see in the amateur golfers, overuse forms quite a small percentage, about 22% of all injuries, compared to the single event traumatic injuries that we see in amateurs. Whereas in professional golfers, it's really very different. You see that nearly 70% of all injury results from overuse, with a small component from the single event injuries. And that's because professional golfers swing the club in a much more reproducible way. They also exert greater forces and more reliably channel them through the same areas of their kinetic chain and skeleton to produce these overuse injuries. In terms of the areas that you see injured, the upper limb is the predominant area, with the wrist the number one area injured, followed by the shoulder and the low back. Lower limb injuries and elbow injuries are slightly less common. We did our own survey in 2013 looking at the European Tour and really found very similar incidences of injury, with 35% of players reporting wrist injury, current wrist injury, or symptoms, and 30% recording prior injury. So wrist injury is pretty prevalent in professional golfers. The leading side is generally viewed as more active, so it was more commonly injured in golfers. And it's important for us to remember that not all injuries are related to golf. There's an increased emphasis on fitness, so we are seeing more lower limb injuries related to gym activity and running activities with bone stress and internal derangement of the knee more common. And we're also seeing upper limb problems with weights-related injury, especially in the shoulders and wrists. So if we look at some specific areas of injury, we'll focus on the wrist to begin with. And I'm going to split this into different areas of the wrist, starting with radial-sided wrist pain. The number one condition that we saw was de Quervain's stenosing tenosynovitis. And this almost universally affected the leading wrist in our players in the questionnaire survey. This affects the extensor compartment 1 tendons of abductor pollicis longus and extensor pollicis brevis, as you can see here, and you get narrowing or thickening of the tendons, resulting in a stenosing tenosynovitis of this compartment. The imaging features are thickening and fibrosis of the sheath, seen as on ultrasound as a low reflectivity halo around the tendon. So here you can see the two tendons, extensor pollicis brevis and abductor pollicis longus, and you can see this halo of hypoechoic tissue around it, typical of de Quervain's tenosynovitis. It's commonly associated with neovascularity, so we see vessels within this hypoechoic thickening with relatively low amounts of fluid present in these cases. Multiple tendons are very common. Often these can't be appreciated until you have this hypoechoic tissue, this dark tissue surrounding the tendons. And when you see that, you see these multiple tendons, accessory tendons within the extensor compartment 1. Retinacular thickening is slightly rarer in these cases. So here you can see the retinaculum of the extensor compartment 1 is grossly thickened. This is a longitudinal view, and you can see it squeezing down on these tendons, almost like an hourglass egg timer configuration, as it's squeezing down, causing this compression of the tendon sheath. And this is quite important when it comes to imaging guided treatment. If you have a straightforward de Quervain's tenosynovitis, then you would probably just perform a guided steroid injection of the tendon sheath. Now, that may sound quite straightforward, but it can be quite challenging, and I'll explain that in a minute, how to undertake that. If you see thickening of the retinaculum, then you would also probably go on and perform needling of the retinaculum overlying the extensor compartment to try and disrupt and release that retinaculum to create more space for those tendons. And if you see thickening of the retinaculum, then I tend to think that that patient is more likely to go on to require surgical release of that extensor compartment 1. The double tunnel is a challenge for landmark guided injections or blind injections of the extensor compartment. So here you can see this is a professional golfer. He's already had one injection for his de Quervain's tenosynovitis, which has failed. And you can see that here the abductor pollicis longus is normal. There's no hypoechoic thickening around it. So this has probably been injected. But the extensor pollicis brevis tendon sheath shows gross hypoechoic thickening around it in keeping with active de Quervain's. And the clue here that there was a double tunnel present is this faceted appearance of the distal radius. It has a tented appearance of the articular surface, which tells you that this patient is likely to have a double tunnel. The actual incidence of double tunnels is very poorly documented. The literature tells us it has between a 25 and 75% incidence. So that's a pretty wide reported variation of double tunnels. We could do with a bit of definitive data on that, really. And the EPB is normally the tunnel that fails to get injected when single tunnel injection is performed. How do I recommend to do the injections? Well, this is my technique of choice. This is the radial artery side of extensor compartment 1. So I tend to come from the other side. It's always useful to avoid any neurovascular structures, I find. And here you can see the extensor pollicis brevis tendon. And your needle, it's only a blue or an orange needle, so 23 or 25 gauge, needs to be inserted between the tendon and the underlying bone. It's important to avoid any close-by structures. So this is the superficial sensory branch of the radial nerve that we're avoiding there. And the reason that I advise injecting deep between the tendon and bone is so you don't get any backing out of the steroid into the subcutaneous compartment to produce dystrophic changes in the overlying subcutaneous tissues or depigmentation of the skin. It can be a more challenging injection than most tenosynovial sheaths simply because there's often not that fluid there that you like to target when you're doing these injections. What about ulnar-sided pain? Well, ulnar-sided pain was similar, slightly higher instance in the trailing wrist as well. So in terms of ulnar-sided pain, about 90% in the leading wrist, 13% in the trailing wrist. What sort of pathologies do you see? Well, the commonest pathology is extensor carpi ulnaris tendon problems, where you see tenosynovitis or tendinopathy, or instability and subsheath tearing. TFCC damage can also cause ulnar-sided wrist pain, as can ulnocarpal inflammatory change from overuse. But for the purposes of this lecture, we're really going to focus on ECU tendon disease. The extensor carpi ulnaris tendon lies within the sigmoid groove of the distal ulna, and as it passes through this groove, it makes a direction change as it passes down to insert at the fifth metacarpal base. And this is maximal, this direction change is maximal in supination and flexion. It has two main stabilizers, the distal retinaculum and a small subsheath. And the subsheath attaches to the distal ulna, which controls its movement relative to the sigmoid groove. The retinaculum tends to control its movement, tends to control the distal radioulnar joint. This is the same data, just shown diagrammatically. You can see here that in pronation, the ECU tendon follows a straight path, but in supination and flexion, it now forms an angle, and as a result, it's more vulnerable to injury to the subsheath, allowing it to sublux from that groove on the distal ulna. Here you can see that in red, the subsheath holding the ECU tendon in place, with the retinaculum passing right round the distal radioulnar joint, stabilizing the joint. The abnormalities that we see in the extensor carpi ulnaris, well, the commonest abnormality would be overuse tenosynovitis, where you see anechoic fluid within the extensor carpi ulnaris tendon sheath, associated with some minor peripheral synovial thickening, as demonstrated here. And that's very typical for overuse tenosynovitis. Tendon damage is the next step of overuse disease. And what you tend to see with that is distortion of the normal architecture of the tendon associated with an increase in size. And in order to demonstrate that, you really need to compare to the contralateral side. So here you can see the asymptomatic wrist has a nice small tendon seen in transverse section. Compare this to the symptomatic wrist, where the tendon is increased in size and heterogeneous, and you can even see small hypoechoic clefts forming within that tendon as it's beginning to develop split tears. So comparing with the contralateral side for the detection of tendinopathy and early split tearing is really important. On MR, similar appearances. You can see the ECU tendon with the split tear running through it, surrounded by intermediate T1 signal tissue in keeping with tenosynovial thickening. The ECU subsheath is really not very well seen on ultrasound or MRI. So you can just about make it out on this ultrasound. You really need very high resolution ultrasound. I think we're nearly there. We're just not quite there in terms of ultrasound detection and with MRI. But when it's deranged, it becomes much more clearly visualized on scanning. The other problem we have with the subsheath is it's not always there. Sometimes it's absent. A little bit like Osborne's ligament in the elbow. It can be absent, and subluxation of the ECU can be seen in normal patients. This was a paper produced by Lee, which showed asymptomatic subluxation and dislocation in 12 wrists where the deviation out of the groove was measured using ultrasound, and you can see it confirms that in the flexed position and supinated position and in all the deviation, you get the maximum displacement of the ECU from the groove. So even in asymptomatic individuals, you could quite commonly see 80% subluxation of the tendon from the groove, which makes interpretation of ECU instability quite difficult. So what we tend to look at is how the tendon moves. So here you can see ECU subluxation in an asymptomatic individual, and you can see how the tendon, which is just here, is gliding. It just moves very smoothly out of the groove as the patient goes from pronation to supination. Compare this to a patient with symptomatic subluxation, and you'll see there's a distinct snap as the tendon dislocates and moves across the distal ulna. So if you just watch, here's the ECU tendon here, and as the patient goes into supination, you'll see it just flick across, and that's a snapping tendon, and that's a much more dramatic movement, a little bit more traumatic for the patient and the tendon itself, and is more likely to be symptomatic for the patient and more likely to produce tendon damage, tendinopathy and splits. Treatment for ECU instability is splintage. So this has a good outcome for acute subsheath injuries, and then tendon stabilization, which should only be performed if there is persisting instability after failed conservative therapy or tendon damage. I'll leave that to Doug to discuss. You see here an MR examination of an acute subsheath tear with bone marrow edema, lots of edema in the soft tissues around the ECU and subluxation of the ECU tendon sheath. Ideally, you should perform MRI in pronation and supination position to confirm instability of the ECU if you do not have ultrasound available. What about dorsal pain? Well, this was predominantly the trailing wrist. So this about 80% in the trailing wrist, 20% in the lead wrist. What sort of conditions did we see? Well, the commonest was dorsal rim impingement syndromes. It does occur both in the leading and trailing wrist. In the trailing wrist, it tends to be golf related due to hyperextension of the wrist and loading. In the leading wrist, we tend to see it more related to gym work. So repeated weightlifting above the head tends to put strain on the dorsal rim of the wrist, as does trauma. Intra-articular bodies, ganglion cysts and carpal bosses also can cause dorsal wrist pain and form really the differential diagnosis for imaging in dorsal rim impingement syndrome. So dorsal rim impingement occurs between the dorsal lip of the radius and lunate in hyperextension. Generally, it occurs past 35 degrees of wrist extension, and the imaging findings are those of hypertrophic synovial thickening. Occasionally, we see osseous bodies or dorsal osteophytes in these areas. The MRI can be quite subtle. This tends to be quite low signal tissue, and radiologists are very tuned in to looking for fluid intensity signal pathology, but in DRIS, it's not always high signal. It's often intermediate signal on T1 and T2 without that high signal intensity present. So this is a patient with dorsal rim impaction syndrome. You can see this sort of chronic thickening of the dorsal capsule. It's very close to the RLT ligament, which may well form one of the structures causing impingement of this tissue. And you see this low signal increased mass of tissue over the dorsal aspect of the lunate. With ultrasound, dynamic ultrasound may show this synovial entrapment, and just like with the ECU, it's a relatively subtle finding, so it's important to compare with the asymptomatic side. So here you can see quite an acute DRIS. You've got this quite inflamed mass of tissue present over the dorsal aspect of the lunate, and an ultrasound, you've got the same thing. You can see this thickened mass of tissue, and as the patient goes, flexes and extended, you can see it sort of trapping and bulging out. What about treatment of DRIS? Well, it's not to be underestimated, really, especially if it's related to golf activity. So it's a difficult condition to treat. Probably the best thing is to avoid any causative factors. And if it's golf related, that's quite difficult, but it may be that it was brought on by a precipitating factor, a change in the weather, heavy practice on mats, something like that. Wherever possible, avoiding the causative factor is the best treatment. You can combine this with imaging guided injections, either of steroids or ostenil. And from an imaging viewpoint, it's important to look for other causes. And this is where looking for dorsal chondro-osseous bodies or rim osteophytes is important. And these do occur. This is a professional golfer with a dorsal rim impaction syndrome that had a quite sizable dorsal body that was causing dorsal rim impaction syndrome. When there are bodies present, these are easier to treat in terms of removal is likely to give a more long-lasting result. Dorsal ganglion cysts arising from the dorsal aspect of the scapha lunate. Again, these sit very close to the posterior interosseous nerve terminal branch, which can be irritated by any underlying ganglion and can give symptoms very similar to DRIS in patients. A carpal boss is slightly different, it's a little bit more distal. It's a hypertrophied bony protuberance at the base of the third metacarpal. Often it's just a bone spur, but when a separate fragment forms, it's also termed an os styloideum. And on MRI, they can be quite difficult to spot. So here's a carpal boss with a thin fracture running through it in a professional golfer. And there's the CT with the carpal boss coming off the base of the capitate adjacent to the third metacarpal base with that thin little fracture just running through it there. So these can be quite difficult and quite close in terms of anatomy to the area where you tend to see dorsal rim impaction syndrome. It can cause some diagnostic confusion. What about bone abnormalities? Well, we do see bone stress, but it tends to be in younger players, so less skeletally mature, and it tends to occur when they first become professionals. So when there's a step up or a change in terms of their activity. Cartilage damage does occur, tends to be in older players or in players who've had multiple injections. So here you can see a young player who made that step up to being a professional golfer. This is quite an unusual bone stress. They developed bone marrow edema in the scaphoid waist, centered around the short radioscapholunate ligament. And you can see they had bone marrow edema, which after treatment eventually settled and returned to normal. This patient, however, when he started playing golf again, developed further symptoms and required fixation of his scaphoid to allow him to continue golf. The classic fracture in golfers is the hook of hamate fracture. This is seen generally in all racket or bat sports. Normally in racket and bat sports is in the dominant hand. In golf, it's the non-dominant hand, and it's felt to be due to the heel of the club hitting into the wrist during the striking phase. It's classically very difficult to diagnose clinically and is occult on conventional wrist radiographs, so can be tricky to diagnose from a radiographic viewpoint. It's very well described in this book from John Feinstein, A Good Walk Spoiled, where this player, John Cook, describes a long 7-year struggle with golf and wrist pain until his hook of hamate fracture was finally diagnosed. This is the typical appearance of an acute hook of hamate fracture, where you see the oblique fracture traveling through the hook of hamate. And this is normally post-traumatic as a result of an acute fall on the hamate, although it can also be seen as an avulsion injury. The fractures, however, are not always that obvious. Here's a golfer where they had a hook of hamate abnormality missed. And you can see that the imaging really wasn't really taken in the correct plane to diagnose the edema. And the only real clue was that the hook of hamate here was white compared to the other carpal bones. And it's a bit really out of the area of interest in the wrist. So it does tend to get missed on MRI scans. On the axial scans, you can see this is the sort of thing we tend to see in golfers, this sort of subtle area of bone marrow edema right at the base of the hamate. And if that's left untreated for long enough, the patient will eventually go on to develop this low signal band of a stress fracture across the hook of hamate. Cartilage damage, I mentioned previously, does occur in golfers. Pisotriquetral cartilage damage is not uncommon. In golfers, dorsal radiolunate cartilage damage is quite common and is probably part of the DRIS syndrome, and triquetrahamate cartilage damage is also something that we've seen in these golfers. Tends to be the older golfers, and treatment tends to be focused around avoidance, symptom prevention. We try and avoid steroids where possible. This is a case of pisotriquetral cartilage damage with secondary osteoarthritis actually developed in this case. Outside of the wrist, there are finger injuries are reasonably common. Collateral ligament injury is probably the commonest. Trigger finger is probably the second most common thing that we see. Acute trauma is uncommon in golf. You can see occasional fractures, mainly avulsion fractures, tendon injuries or volar plate injury in golfers. The collateral ligament injuries are very difficult to diagnose in ultrasound or imaging terms. It's normally very subtle edema that you see around the site of these collateral ligament injuries. and they're quite difficult to treat. So this is an PIP joint ulnar-collateral ligament injury where we treated it with 20% dextrose prolotherapy, low-dose intra-articular steroid, and the patient got a good result with that steroid injection. But I think the treatment really is one of modification of technique and avoidance of injury, if at all possible. Shoulder injuries were reasonably common in golf, and these tend to comprise a combination of either impingement, cuff injury, or cuff injury, with the lead shoulder the most commonly affected site. So a couple of cases just to show you what sort of things we see. This was a 27-year-old European Tour golfer who complained of shoulder pain, had an MR scan which showed this quite dramatic appearance with altered signal within the tendon, some linear fluid signal within the tendon, with quite marked thickening of the tendon and some bursal fluid. The diagnosis here was that of a partial thickness tear, and the player pulled out of the tournament. His ultrasound scan was actually normal when he actually got back to his home country. And really what we're looking at here is impingement with tendinopathy and swelling of the tendon. And 5 years later, this player remains in the top 100 without any interventional treatment whatsoever of his shoulder. There are some specific shoulder injuries that have been reported. Hovis reported in 2002 posterior instability of the shoulder in 8 elite golfers. I don't think this has ever really been confirmed. I think they were looking for the same sort of conditions that you see in baseball pitchers, where they, due to repetitive action, they get limitation of movements and abnormal movements in the shoulder. I've not seen this repeated in the golfers that I've seen, and I've not seen further reports since 2002. So although this frequently gets quoted as being a common golf injury, it's not really something that I've seen in my experience. Finally, just to talk about the elbow, two main abnormalities that we see in golfers: golfer's elbow, obviously, and tennis elbow. In fact, we actually see tennis elbow much more commonly in golfers than golfer's elbow, and it tends to be the older players. Golfer's elbow is a tendinopathy, overuse injury, and it's characterized by sort of the universal findings of tendon disease. At ultrasound, you see thickening of the proximal tendon with this increased fluid component within the tendon that shows up as being slightly darker, with poor definition of the tendon fibrils. Lateral epicondylitis looks exactly the same as medial epicondylitis. So you have this low signal tissue with neovascularity. On MRI, it tends to show this thickening of the tendon with edema in the tendon, and occasionally you get tendon tears associated with it. It's normally patients that have had previous injections of steroid that develop these tears. And when you're looking at tears, what you want to look for is this dip in the superficial surface of the common extensor origin or common flexor origin, a bit like you would in a rotator cuff, where you see this dip down where there's missing fibers and absent tendon. In terms of treatment, if you undertake rest and rehabilitation, about 80% of these will settle, and about 20% are refractory. And there are a variety of treatment options we can perform by injection, steroid injections, blood product injections, or even botulinum toxin injections. There are a number of reports and meta-analyses that have been undertaken, and the general view is that steroid injection offers reasonably good short-term relief, but in the long term is actually detrimental to the patient's function and long-term pain scores. So in general, we try and avoid steroids due to the long-term outcome. So the focus really is on blood product injections, either autologous blood or platelet-rich plasma, and some centers undertake botulinum toxin injection to reduce muscle tone on the tendon itself. And if the patient is recalcitrant to all treatment, then obviously surgery remains an option, but much less so than was previously the case. So one of the things always to remember when you're imaging golfers is the linked chain analogy, a bit like the medical service, really. The golf swing is highly complex, and I quite like when you watch professional golfers hit a golf ball. What always impresses me is that nothing looks rushed. It's very slow movement, and I like the analogy of a train moving on a train on a train. So it's a little bit like they slowly build up the speed, so the hips move at a certain speed, then the spine on top of that moves a little bit at the same speed, but when combined, it's now a train moving at 20 miles an hour on top of a train moving at 20 miles an hour, and then the shoulders move at 20 miles an hour. So now the whole thing's moving at 60 miles an hour, and when you combine that with the wrists moving, you tend to build that speed effortlessly. And where the linked chain analogy comes into it is when you get a problem in any of these points, it tends to place stress elsewhere in that motion. So this is an example of a 29-year-old golfer who presented with sternoclavicular joint pain or sternal pain. You can see he's got this tremendous inflammatory reaction at the sternoclavicular junction. It was difficult to imagine why a golfer would get problems at the sternoclavicular junction, but it wasn't until we looked at his spine and we saw that he had a 2, 3, 4, 5, 6, C5-6 prolapsed intervertebral disc. And when we looked at his upper thoracic spine, the discs were really quite dehydrated and small, very limited movement like to be present in these discs. And so what you're looking at is a player with limited upper thoracic and cervical spine movement who is, as a result, placing too much load on their scapular thoracic and clavicular movements, producing this inflammatory reaction at the sternoclavicular joint. And it's similar that if you have a wrist or an elbow problem, it's important to examine the shoulder to make sure the shoulder movements are normal, and that what's happening is not a problem occurring in the wrist because another part of the body isn't moving correctly. So in summary, really, I'd just like to emphasize that imaging golf injury is challenging, and it's very asymmetrical. And I think you really need to appreciate the nature of the golf swing and how injuries occur in these golfers when you're undertaking imaging procedures. Thank you very much.